Well, everyone, thanks for joining us tonight. I appreciate everyone's attendance. I'm Dr. Jason Pope. I'm the chairman of PSPS, which is the Pacific Spine and Pain Society. And since our inception, we've really tried to embrace the partnership of surgeon and interventional pain physician, trying to collaboratively treat people and give them access to care, both innovatively and also with evidence, grounded with evidence. And I think part of that comes with really embracing the partnership that we have with advanced practice providers. So really, we wanted to get a webinar together to not only talk about that partnership and embracing that partnership, but also talking about how PSPS can support you in your journey being an APP in this world of spine and pain. I want to thank SPR Therapeutics for sponsoring the webinar. And I think as PSPS has grown, we really want to again focus on growing our membership for APPs, and I can speak pretty candidly within my practice that when we bring on advanced practice providers, the thing that I've noticed in talking to other colleagues is really that there's not a lot of formal education on interventional pain and surgical expertise within formal training. And so a lot of that is done piecemealed and a lot of that is done through society work. And so we want to, again, promote a good partnership and also promote education along the way. So we have an expert panel of faculty, and I really applaud and appreciate, and I'm humbled that they're here to join us tonight. We have Patrick Buchanan, Dennis Patterson, Victoria Flower, Kelly Gator, and we're going to have them introduce themselves as they go through their presentations, and then we'll have an opportunity for a panel for questions. So without further ado, and this is our sponsor, and again, I really appreciate the partnership with Sprint and SPR Therapeutics. They've done a really, I think, an innovative job in treating pain minimally invasively. And we'll talk a little bit about their therapy specifically as we go through the presentation. But without further ado, I'll hand it off to my friend and colleague, Patrick Buchanan. And Patrick, let's get rolling.
Thank you, Jason. I appreciate it. Welcome, everyone. My name is Patrick Buchanan. I'm a interventional pain physician in Camarillo, California, which is kind of just north of LA. I've been practicing there for about 7 years now. In our practice, we have 5 pain docs and 3 PAs. So, the PAs are crucial in our practice, and we work with them really well. So I'm here to talk about kind of the pain management landscape in general, and kind of how this fits in, and why there's such a demand for our field here. There's kind of a shift in how we treat pain. Back 5-10 years ago, pain was the 5th vital sign, and there was a very hard focus on all these heavy medication opioid managements to try to get down their pain levels to as minimal as possible. Well, that's kind of shifted now that with the CDC coming out with their guidelines, as well as all these novel procedures, now we're focusing on treating the pain generators themselves and getting directly to the pain source with all these different interventional therapies. So I think that's a big shift that we have to be aware of. We're trying to get out of the major hospital setting and go more into the ASCs, the ambulatory surgery centers. We're all trying to shift to that less complications, less hospital stay. I kind of compare it to back in cardiology, back when they were doing all these open heart surgeries, and then the cardiologists started doing these interventional caths and valves, and kind of just changed the way that we treat heart disease. And kind of this is the same way in the spine is we're developing all these minimally invasive procedures that are more effective, less complications, and less hospital stay, and better outcomes for our patients. So I think there's been a big shift in that. And also, there's been a significant increase in research and developing novel therapies. This is a great time to be in our space right now, where there's so many, companies devoted to research and technology. It's just a great time to be in our space. So I'm going to just briefly discuss about the role of APPs. I know Dennis is going to talk about a little more in depth for you with you guys, but you guys are really, I call you guys the gatekeepers of our practice. Sometimes you guys are the front lines, the first ones seeing our patients. So you're right there diagnosing where their pain generators at. Through a thorough H&P physical exam. And here at PSPS, we have different tools we can help you guys with too if you are not comfortable diagnosing different conditions as well. We have different workshops. I think Jason's going to talk about that later on. Also ordering different image studies and reading your own imaging, what to order, when to order it, and then creating a treatment plan, that's best going to help with your patient outcomes, I think. Some PAs and nurse practitioners also assist surgeons in the OR, whether it's closing, suturing, and that kind of stuff. You guys also play a crucial role in spinal cord stimulator management and intrathecal pump management after the surgeries as well. So if a patient's not getting, relief with the stimulator, checking, x-rays, making sure there's no lead migrations, partnering with the reps to make sure they're getting the right stimulation and coverage. And then intrathecal pain pump management. We have, I think, the second or third largest pain pumps clinic in California. And Dave Davis, he does a great job of helping manage the pain pumps, making sure they're refilled on time, making sure everything's running smoothly. And then I think one of the most important things for APPs is patient education and really building that patient relationship and trust with them, because a lot of times you guys are going to be seeing them more often than some of even the pain docs or the surgeons, just depending on how you guys are set up. So really educating the patient, making sure they're bought in, making sure you talk to them about the risks and benefits and about the different therapies we have is going to be a crucial role. So I'm just going to briefly talk about kind of what we offer as an interventional pain practice. What I like to say is we have kind of different tools in our toolbox to help our patients out. And you kind of go from the most conservative, which is physical therapy, medications, to more invasive things we can do. So kind of just setting up that treatment algorithm is really important in your practice. So you have different medications, like I said, trying to avoid the opioids and go into more of the non-opioid combination of medications. There's different medications for different indications. You have your NSAIDs, like your long-acting Mobix and Celebrexes for kind of that inflammation, anti-inflammatory pain. Obviously, the anti-seizure medications, the pregabalin and the gabapentin to help with more of that neuropathic kind of pain, as well as some of the antidepressants too. A lot of those can help with both mood, sometimes even sleep and pain. As we know, this is a very multifactorial problem, and treating with these different medications, different routes of pain, and hitting the different kind of receptors ultimately will lead to less complications and side effects with your patients, as well as more effective and hopefully more compliant treatments. So if the medications and physical therapy is really not cutting it for your patients, the next step would be the injections. And these are kind of like your bread and butter injections. Epidurals, you can either go interlaminar, which is kind of in the middle of the epidural space, or transforaminal if you're looking at targeting a single root, trying to diagnose exactly which area that radiculopathy is coming from. If it's more axial back pain, more with leaning back or facet loading, you can target the arthritis in their back with facet injections or medial branch blocks. And then in the office for your musculoskeletal issues, right? We treat shoulders, we treat hips, we treat knees. So you can do injections for that, whether it's steroid injections, viscosupplementation, and then we have all the other regenerative stuff too, like platelet-rich plasma, PRP, stem cell therapy. So, we have, like I said, a variety of things we can do to help with joint pain as well. And then patients suffering from CRPS or causalgia, the first start you can do are some nerve blocks, whether it's a lumbar sympathetic for the lower extremities or stellate ganglia for the upper extremities. Um, the next step kind of is the radiofrequency ablation. These are not surgical procedures, however, they are, um, longer term, hopefully, therapies for the patients, lasting anywhere from 6 months to a couple of years, depending on, how they do. But, you can do radiofrequency ablations. Thermal is pretty much the most popular or conventional one, just because of insurance as well. You can also do cooled or pulse. And there's different targets you can use for these radiofrequency ablations. Most commonly is the spine, the cervical and lumbar spine, but you can also do for knees, hips, shoulders as well. And then a new kind of therapy that's really come on is the basovertebral nerve ablations for vertebrogenic pain as well. So if they have motor changes in their body and they have, axial back pain, this may be an option for them as well. So if these kind of frontline butter injections, fail or they're just temporary, the next step would be the minimal invasive spine procedures. And we have a lot of tools, like I said, at our disposal for this. Some of the ones that you've probably heard of most commonly, spinal cord stimulation, whether that's for, failed back pain. There's now new indications for this for even non-operative virgin low back pain, as well as CRPS and all the other ones. So there's two types of spinal cord stimulation: dorsal column, where you can see on the upper right hand, more for that generalized, low back and leg pain, or DRG, dorsal root ganglion stimulation, and that's more for that kind of focal neuropathic pain that you have. Maybe if it's a foot and ankle pain after ankle surgery, or a knee pain after knee surgery, or groin pain after hernia surgery. If you want that targeted approach, then you would go with DRG stimulation. Peripheral nerve stimulation has really come to the forefront now. Sprint is training a lot of physicians on different targets that we can use that maybe dorsal column or DRG stimulation can't capture, like shoulder pain and other areas of the body as well. Then you have your indirect decompression, direct decompression. Basically, the indirect decompressions for spinal stenosis. You can put a little um, piece of, I guess, backstop in between their spinous process to help prevent that flexion and extension there. Direct decompression, basically, or the mild procedure, basically, you're kind of taking off some of their ligaments there to help free up some of the central stenosis as well. Sacroiliac joint fusion has also become a popular option, long-term option for sacroiliac joint pain. Now that Medicare has kind of cut radiofrequency ablation out, there's really no other long-term options for our patients. So, sacroiliac joint fusion is a great therapy for long-term treatment of SI joint pain. And then, as I talked about before, intrathecal pumps we have, and then kyphoplasties for fractures. So, kind of developing a treatment algorithm. This is kind of what I use in practice. This is a little sample here. Give a shout out to Dennis Patterson. He's the one who helped create this algorithm. I'm just stealing it from him. But, here is kind of like how we think in our practice with both, we're all on the same page, the APPs and us as physicians. So we all have kind of one kind of algorithm that we go by. So it's very easy for the patients as well. So this is just an example of one for SI joint dysfunction. So kind of takeaways, like I said, it is really an exciting time to be in our field now with all these therapies and kind of the shift to go to more minimally invasive, targeting those pain generators in our practice. You guys, like I said, are the front lines, are the gatekeepers to many practices. So, as there's more and more need for pain physicians as the baby boomers, get older. We're going to need as many APPs as we can to help try to treat and diagnose these pain generators as well. I think I'll be handing it off to Dr. Dennis Patterson now to talk about the APP models.
Hey, thanks, Patrick. I appreciate that. Hard act to follow, but I'll do my best. So I'm Dr. Dennis Patterson. I am a physical medicine rehabilitation doctor who does interventional pain management in Reno, Nevada. Been in practice for about 15 years, and Gal, I've kind of early embraced APPs and incorporated them into my practice. And so anybody out there who's thinking about adding them or has them and thinking about changing their model, here's my contact information. Feel free to reach out to me anytime. I'm an open book. I'm more than happy to help out anyone at any time. So the first thing I'm going to talk about today is I'm going to talk about different APP models, and specifically 3 models I'm going to look at. And then we'll talk about scope of practice next. But with the APP models, I think there's several different models we're going to look at here. And I think what you may find is they may evolve or change, or maybe on a month-to-month basis, or as your relationship with your APP develops, the model may change just naturally over time. But what you're looking to do is you're trying to set, a foundation. How is your practice going to utilize them? What is your understanding on how you're going to utilize them? What's their understanding on how what your expectations are? And it just kind of sets the foundation so everybody knows, who's the leadership, how to be professional, how to behave with one another, and overall, how to provide efficient, good, high quality care for your patients. So let's look at the first model here. This is an independent APP model, and this is where the APPs lead the clinic. So in my clinic, I'm very fortunate. I have, about 5 advanced practitioners currently. All of them have been with me for a minimum of 2 years. So they've been trained. They understand what I do. They're pretty much independent at this point. They're able to see initial consultations, diagnose, recommend a plan of care, and prescribe medications to the patients. And really, they follow up with a plan of care. And when I get involved is a couple of reasons. Number one, insurance requires it, especially with the new patient evaluations. So Medicare patients, I will see them, but I'll see them through the APP. So the APP will get the history, do the physical examination. They'll kind of give them a diagnosis, indicate what the treatment plan is. They'll come grab me. I'll do a brief history, brief exam, confirm the diagnosis with them, and then tell them what my recommendations of the plan of care are. I step out, the APP finishes the evaluation and educates the patient. But that's really with my independent APPs. That's the only time I get involved is with the new patients where the insurance mandates it, or 2, on follow-up visits where either the plan of care we've created hasn't worked and they're stuck and don't know what to do, or 2, they want me to come in and be the bad guy and basically tell the patients what the practice protocols and rules are that I've established and that they're just following them. So the independent ones, that's kind of where my practice is right now. But like I said, these APPs have been doing pain management at a minimum of 2 years. Some of them have been with me for a decade. And so it's easy, they understand me, I understand them. There's a lot of pros to this. One, it kind of frees me up. I'm doing procedures 5 days a week now. I'm not bogged down in clinic. And I think the pro for the APP is I'm letting them operate at their highest level, independent. They can actually run a clinic. That's what they're trained to do. But probably the downside would be is I lose a little bit of that touch with the patient. The patient now thinks that they're their provider. I'm not. They only see me when they're having a procedure done. I think here, education is key. You want to make sure that if you're going to turn your APP loose, you're ensure that they, continue to be have ongoing training and different specialties like in orthopedics, neurosurgery, psychology, since our practice, incorporates a lot of those different principles. You want to make sure they're up to date on their CMEs, attending webinars, conferences, and doing literature reviews. So they're at the cutting edge. You want to make sure that the practice has clear, accessible protocols and procedures in place so everybody knows what their rules are. And then on top of that, I think it's very important to have constant feedback with them. And so at least once a month, I have an advanced practitioner dinner where we all sit down, we have an agenda. They can bring items, to the dinner, and we just talk everything out and make sure that we're all on the same page and offering the same quality, consistent care across the clinic. The next one is kind of more of a collaborative, and this is more kind of a physician-run clinic with the APPs following up on everything. So this is where the physician sees all the new patients, establishes the plan of care, and then sets the APP up to see the patient for the follow-ups and ensure that the plan of care is being done. Um, so, I'll see a patient today. A month later, the patient will follow up with one of my advanced practitioners and make sure that the patient is being compliant. This is, one of the pros of this again is, this is less clinic time for me. So, maybe I'm doing 4 days of procedures a week. I'm doing 1 day of new patient evaluations. The patients still feel like I'm involved in their care and that I'm their physicians. The cons is, once again, this is taking away potentially a day that I can be doing advanced procedures and treating patients. And at that, and kind of to the APP, maybe they feel like they're not as independent and able to run a clinic like they should. So you should consider this model maybe with new hires, especially after they get trained and seem to be getting up to speed. Doing those new patient evals or working hand in hand with the clinic may allow the APPs to kind of understand your tendencies, what your plan of cares are going to be, so they can kind of read your mind beforehand and help manage these patients. Um, and once you've built that trust with working with them for a period of time, then maybe you can transition them to an independent model. And you got to remember, independence, and we'll talk about that in my scope of practice, may be dependent on the state of laws. And then this is dependent. This is where basically the physician does all the clinic. They see the new patients, they do the follow-ups, which involves change in care plans. Basically, the APP just sees patients for usually med refills, no changes in the care. The pros of this is now the physician has control and trust of the patients, but the con is that they're spending more time in clinic and less time doing procedures. It's very difficult with scheduling in these situations because where are you going to fit patients? It's only certain days that you're doing the office work versus procedures or being at the surgery center. And I think the other con is this doesn't give the APPs the autonomy they were trained to do. Next slide. I'll just kind of give you a quick summary overall. In my clinic, where I've seen is that early in my career, I started out more with the dependent model. I felt like I had to be the patient's champion. I had to see them all the time. They had to keep that interaction. And I think I've learned that that's not necessary. I need to be doing what I'm trained at my highest level, and that's doing advanced procedures and being in the procedure room and in the OR. APPs, their highest level is to run a clinic independently. So usually my new hires, I'll probably have them more on a dependent model. They'll shadow with me, work with me for about 4 to 6 weeks. We will then translate to the collaborative, where we'll do clinic together for 4 to 6 weeks. And then after that trust is built, I let them run the clinic independently, and they know by the procedures and protocols we have in place when they need to notify me or talk to me about certain situations, so I can help them out. Let's go into the scope of practice here. So first of all, there's an advanced practitioner. What are we talking about? We're talking about your APRNs. We're talking about your certified registered nurse anesthetists. We're talking about your physician assistants. And in some cases, we're even talking about your certified anesthesiologist assistants. And, when you're looking at scope of practice, it's going to break down into 4 critical areas. There's federal regulations regarding what advanced practitioners can do. Then that's going to come down to also state levels. I'm going to show you a state map coming up, showing exactly what states where APs and or APRNs and PAs, kind of what they're allowed to do. And then there's another level, which could be an institutional level. So like a hospital system, they may have certain regulations on what advanced practitioners can do inside their institution. And then last but not least, it gets down to the individual level, where it's the individual and the physician who's hired that APP. What is their understanding and what are the rules and regulations that they have between each other on their scope of practice. There's a lot of overlap between physician assistants and nurse practitioners. As you can see here, usually nurse practitioners have 2 to 5 years of master or doctoral training. Physician assistants is usually 2 to 3 years. If you look at renewing their certification, the physician assistants is every 10 years, while the nurse practitioners is every 5. They have different, accreditation or boards that they have to report to in some states. So let's look at nurse practitioners. So if you look at what they're allowed to do, so they are allowed but not limited to assessment, ordering, performing, supervising, interpreting diagnostic and laboratory tests. They can make diagnosis. They can initiate and manage treatment. They can prescribe medications, whether they're they can recommend non-pharmacological treatments, coordinate care, counsel, and educate patients, families, and the communities. They can perform autonomously in certain states. And this is what I want to show you. The scope of practice for nurse practitioners, it kind of in the United States falls under 3. You've got your ones that can operate independent or full. You've got some that it's limited, and then you've got other states where it's really limited. And I was actually kind of surprised to see this. So in Nevada, my advanced practitioners that are nurse practitioners after 2,000 hours, they can operate independently. I didn't have to sign their notes. I don't have to look over their plan of cares. In California, now put an asterisk here, the regulations are changing, but in that state, they have to fall under a physician. Physician has to set up the plan of care, set up the treatment, and in some instances, prescribe the medications for them. I'm almost done here, and we'll get moving on. So as you can see here, we're a West Coast society. I just wanted to point out the states where have a reduced authority, and that the ones that are important here would be Utah for our society, and restricted would be California. But pretty much all the other states that are part of PSPS have a full practice autonomy. So physician assistants, so they can take medical histories, perform physical examinations, order and interpret laboratory testing, diagnose illnesses, develop and manage treatment plans for their patients, prescribe medications, and assist in surgery. They're usually part of a team practice that has evolved over time. But once again, you'll see there are different states require different regulations that limit the PA scope of practice. And so you may want to take a screenshot of this. This is pretty small, but you'll see that there's 20 states that require that the co-signature by the overseeing physician. There are prescriptive states where they don't have as much authority and can prescribe Schedule 2 to Schedule 5 medications. It looks like 44 states allow that, but there are a few states that don't. And for us, I just want to point out that in Hawaii, that they cannot. And then you have to have a collaborative or supervisor agreement. So the physician and the PA have to have a separate agreement on paper that is signed. That happens in 2 states, but that's Arkansas and Illinois. You don't have to worry about that. Here's some resources for you guys to look at after today's presentation. If you're interested about scope of practice, the state you're in, you can find more here. And I'm going to once again turn it over to my friend, Pat Buchanan, to talk about society engagement and advocacy. And hopefully we can get through this to get us done on time tonight. So thanks, Patrick.
Thanks, Dennis. Great job, man. So like as Dennis said, if you guys are interested in getting involved in any of this stuff or have any questions or anything, this is my email as well. Feel free to email, reach out to me. We're more than happy to help you or guide you to where you want to go. So I'm going to talk a little bit about society engagement here. So the advantage of going to these society meetings, right, like PSPS, you got to fulfill your CME requirements, number one. These PSPS society meetings have specific tracks, focused on the needs of you guys, whether it's reading how to read MRIs or physical exams or, treatment algorithms. Jason's going to talk about later about the upcoming programs that we have, but we're really trying to change this to really focus on your needs as well. And we also are trying to build, that support group with you guys, with the physicians, with everyone. I kind of think of PSPS kind of as my own little family too. I started out probably a year or two out of working in my clinic, and started getting involved in these societies. And I've been able to make great friends with Jason and Dennis, and it's great to see them at every one of these meetings. And we collaborate on different studies, as I'll talk about in a little bit. By going to these societies, you also get a lot of exposures to different therapies, as I talked about earlier in my minimally invasive slide, to the pain and spine fields. It seems like every single meeting or year, there's something new coming out to try to help our patients more. So it's great to be up to date on all the latest therapies and the data behind those that we have. And also it can bring about consulting and research opportunities. I consult for a couple of different companies. I've been fortunate enough to be in some of their studies as well. So if that's kind of interest you had as well, and teaching your other fellow APPs and kind of becoming key opinion leaders for them as well. I mean, this is a great opportunity to get involved with that too. So what to look for when you go to these societies meetings, right? There's going to be a lot of glitz and glamour there. You have all these industry coming at you, talking about why their product, is the best. You have a lot of these different lectures or topics about the groundbreaking data behind these therapies as well. So, you got to really determine, what's best for you in your practice. So the first thing is this therapy appropriate to my patient population, right? So, as you develop your treatment algorithm, it's looking at, which therapies are, have long-term outcomes for your patients that are least minimally invasive with the least amount of complications. The second thing I look for when I'm talking to these industry is the level of evidence, right? What is the level of evidence in your current product or therapy? Do you just have retrospective studies that have a poster presentation for, or do you really have these level 1 randomized controlled trials that are looked at over for a year or two for this? So that's extremely important to look at the level of evidence behind a lot of these therapies. Also the complication rates, right? You want to try to avoid as many serious adverse events as possible, right? Our code is do no harm to our patients. So if some of these therapies may be too invasive for you or your practice, and the data supports that, maybe you want to stay away from those, maybe the less minimally invasive ones as well. And then also down the road, insurance coverage is going to be important. Reimbursement. Unfortunately, these kind of dictate what we can and can't do within our surgery centers and hospital settings. So that's really important to also discuss with these different therapies as well. So if you want to be, get involved, you can join one of these committees at Psps. We have 6 great committees right now. We meet once a month on a Thursday night and talk about everything that's going on. If you like the annual conferences, you can get involved with the annual planning committee. They organize everything from the venue location to the date to the hotel you're staying at. They organize the whole agenda. They get to pick, the faculty and different training sessions inside the meeting as well. So that's great if you want to be involved in that one. Diversity and Inclusion Committee, this really gives a voice to those underserved kind of populations, underrepresented groups, and allows them to promote for, other leadership opportunities. The Education Committee is great. I mean, this is what we have right now. So, doing webinars, doing didactics, if you really love teaching, great to get involved in that. The membership committees, and we could use a huge help with you guys in terms of getting the APPs involved. If you have any unique or innovative ways to get, membership up, we would really appreciate that. The Policy Advocacy Committee, this is one of the most important committees, I think, in here. They really help give evidence and support to help dictate insurance coverage to make sure all these therapies are covered. And the last one is the Research Committee. I'm one of the co-chairs of the Research Committee. We tried to evaluate and create research projects as well as publish papers to make sure that we're bringing the highest quality of evidence to these interventional pain procedures. So how to get involved? One way you can do is you can contact Trista. She's very, very responsive to everything. This is her email here. Or you can contact me or Dennis. Like I said, we're very receptive to hearing your thoughts or opinions. You can choose a committee to get involved in. Another thing you can do for this upcoming annual meeting is to submit an abstract or a research grant for the annual meeting. Right now the annual meeting is going to be in Hawaii, not a bad place to go. We're going to be picking 2 abstract winners, and that's going to cover 2 nights stay at the conference in Hawaii, pretty nice, plus a $500 travel voucher. And then if you want to submit a research grant, PSPS will grant up to $5,000 for your research and present at next year's conference, which will cover that stay as well. And like I said, spreading the word about your fellow to your fellow APPs and your own societies as well. To try to get involved too. So we would appreciate you guys doing that and welcome any help that you guys are here to offer. I think that's it for me. Now I'm going to hand you over to Victoria. She's going to be talking about kind of her own unique perspective as a nurse practitioner as well.
Thanks so much, Dr. Buchanan. And I just kind of wanted to say thank you to PSPS and SPR Therapeutics for championing the contribution of APPs and what we're doing in this space. So thank you so much, you guys, for having us on. And my name is Victoria. I'm a nurse practitioner. I work in Northern California with Dr. Samir Sheth. And I started working in various different practices. I started in dermatology, worked my way to interventional radiology, neurosurgery, and now interventional pain. So I'm excited to be able to share with my fellow APPs how to grow in their practice and maybe how to get started if you're there or how to continue to grow. At the moment, there seems to be an imbalance between the number of pain patients we have and the number of pain physicians we have. So I think APPs are poised to really help bridge the gap in this space and collaborating with our physician partners to increase access to care and freeing them up to do more complex procedures is definitely something that we can do and support. So I'm so excited that we are able to talk about this more. And the first thing I want to talk about is the pace of our practice. So I've been fortunate enough to be in a couple of different types of practices. So I want to break it down between large institutions and private practices. Large institutions like the one I'm in is kind of a blend between private practice and I guess maybe a portion of what academics might be. So it's a little bit of a blend, and then talk about private practice. They can be very similar, but there are obviously pros and cons to each. Much like everything else, there's always a pro and con. So just to talk about the pace of the practice, you'll find in large institutions and private practices, because they are very similar, are fast paced and high volume. The differences may be in patient hour availability. So, where I am in the large institution, I have a patient hour availability minimum that I have to meet. In private practice, this may be something that you can negotiate based on the needs of the practice. So, for me, I have a minimum of 36 patient hours I have to have, meaning scheduled time that I'm seeing patients, and then I get 4 admin hours, but we all know we do way more than 4 admin hours in a given week. So I find that maybe the private practice probably values the work that we do a little more than some of the large institutions. And as far as salary goes, there are options. In the large institutions, there typically is a salary plus productivity bonus. And then there's a much greater option in a private practice where you may have hourly salary, or you may get that plus a productivity bonus. You might get a blend of all of those. So there are obviously benefits to each. Schedule availability requirements. Again, in private practice, that can be negotiated. So, depending on the needs of the practice, maybe you work a half day, maybe you have to work weekends. So, those can kind of be discussed. Where I am, I do have schedule availability requirements, or I should say, encouraged scheduling. So, we do try to offer to certain patients times that are outside the normal range. And we are highly encouraged to have these options. So that's just something to think about as far as the pace of the practice. And the pace of the practice sometimes can be determined more on your patient load. And so you might find that in both practices, the larger institutions have greater access sometimes to the number of patients than private practices based purely on insurance contracts and things like that. And so that might drive the pace of the practice. In our particular institution, we're pretty inundated at the moment, so our pace is fast and our volume is high because we only have so many hours a day, and we try really, really hard to give our patients access to care. So sometimes it just means we're seeing a larger volume of patients. As far as support goes, so support can mean many things. In this regard, how I'm defining support is support from ancillary staff. So schedulers, medical assistants, nurses, that type of support for us in a larger institution is based on production. So the number of staff we're able to get is based on what we produce for the most part. There is some gray area, like there normally is for most things. In private practice, some of this can be discussed. It can be negotiated and it may be dictated by your practice manager or the practice CEO. For us, when I first started, when I was in neurosurgery, I didn't actually have a medical assistant. I had to share one with the surgeons that I worked with. So those are some things that maybe can be difficult in a large institution as opposed to a private practice. And then changes that need to be made. Obviously, in a larger institution, there are a lot more policies, committees, things like that that you have to kind of filter through to be able to make some changes. So, for instance, if I wanted to change my current schedule, if I was seeing, say, patients from, I don't know, 9 to 6:30 and I wanted to change it from 7:30 to 5:30, then I would have to go through management, and then management would have to agree, and it would have to potentially go through HR to make sure I'm meeting my hourly requirements before any of those permanent changes can be made. So that can sometimes be a little bit challenging in a larger institution. Now, in a private practice, depending on the size of the practice and availability, you may be able to negotiate that with your practice management team or with your CEO so that you're able to either see patients more or have some flexibility in your schedule. So, those are kind of the pros and cons to having more flexibility, individuality, and then kind of more red tape. And as far as the larger institutions, I am fortunate to have a really robust HR team as well as an APP leadership team. So if there are any changes to policy in regards to, say, NPs in practice in California, I have an APP leadership team that I can go to and hundreds of APPs that I can reach out to in our section meetings to ask questions about these policies, how they're interpreting it, or maybe what they're doing to meet these requirements or changes. So, for instance, in California right now, as Dr. Patterson mentioned, there is a change where we're starting to go to full practice authority, but there are a bunch of things that need to happen before that. And it can be very confusing. And for a lot of us, when we're not sure how to approach it, I have a team of people that I can reach out to help me with that. So that is really beneficial. And that is something that is really nice to have, to know that even if they're in different departments, or even if they're in, different specialties or anything like that, I can actually reach out to them or to the leadership team to kind of help with some guidance. The benefit, though, of being in a private practice with some of the support that you get with the smaller HR team, you also get more personal time. So, meaning your HR person knows you. My HR person may not really know who I am because I'm one of hundreds of people that they have to kind of work with. So, that's kind of the benefit to that. And you might get a little bit more personal support if you need it. Same with your leadership team. If there's something going on, you may be able to talk to one person, whereas, I have many layers of people that I may need to go to if I have an issue before something gets solved. So there are some benefits to having a smaller team, and there's also really robust policy resources. So if I'm not sure about a certain policy, or maybe if there's an issue with malpractice, or let's say you're getting deposed or something like that, then you have a large team that you can reach out to, and maybe a legal team that can help you. So that's kind of the benefit of a larger practice. And you may still have that option in a private practice, certainly. If you have legal counsel for your private practice, you can certainly tap into them. But the same thing is, when it's smaller, they may know you better, which is really nice sometimes. And as far as CME goes, so this is, one of the things that Dr. Buchanan brought up too. And CME is super important for us, as, the pain space, as you know, is changing, and it's changing rapidly. And so to be able to learn about all of these different things coming at us, it's really nice to have a stipend to help pay for them, because they are quite expensive, except for PSPS is relatively affordable. So it's a shameless plug for PSPS annual meeting, which I will do a few more times today. But there is for us a limited CME credit for this. So for us, we're limited in the number that we have for amount, and then that might change for private practice. Okay, there's a lot of information here, but basically, I want to tell you the things that helped me when I first started out. So when I first started out in spine, I knew nothing, and because I knew nothing, I needed a lot of support, and it was difficult to find. So I found my experience in radiology was super helpful. So if you can shadow radiology, that'd be great. Shadow neurosurgery, my experience in neurosurgery was so helpful, and it helped me so much in pain. So if you can find some time to shadow, same thing with orthopedics, shoulders, knees, hips, those can be really complicated. And I also want to plug the APB course at the PSPS annual meeting. Lots of great information there. So if you can make your way to the meeting, there's a lot of great information on new technology coming out too, and it's a great networking opportunity to meet lots of people and other APPs. And then stuff, that Dr. Patterson and Dr. Buchanan talked about, Journal Club, and you can curbside consult. So I have done many shameless reaching out to many different physicians from different specialties to help me figure things out. So don't be afraid to do that. Ask lots of questions, call radiology, go to your society meetings, go to workshops, go to training programs, and then build relationships with your colleagues so they can act as sounding boards. Okay, so final conclusions and commentary on things to help you succeed. Collaboration is key. It is so important. Without a supportive physician, the APP physician team model will not be successful. So hopefully the physician can present the team as a team that working together will optimize the patient outcome. Investment in yourself and in the team is super important. Learning curve is steep, so give yourself some grace. There are lots of resources. I'm going to plug PSPS annual meeting again, so I hope to see you guys there. And find your tribe, resources, and people, teams that you can count on. Okay, I'm going to pass it off to Dr. Kelly Gator, and she'll talk about the academic institution and research availability.
Thank you so much, Victoria. I really appreciate the introduction. So we're running pretty short on time, so I'm just going to go through a couple niche things that you can do aside from seeing patients with the day-to-day. So I work at a larger academic institution, and when I went back and got my doctorate, I really wanted to focus on quality improvement. And so pain and spine care is an amazing way to do that. It's a great way to get involved because really as APPs, we're on the front line and we're seeing patients every single day in clinic. And so we really get to see the gap between the physician and the patient, and sometimes where ancillary staff comes in. And so it's really interesting to problem solve and to find those issues, collect the data, and then start a quality improvement project, which I've been able to do, and you can really feel a sense of autonomy in the practice. So just to highlight, building on what the physicians talked about earlier, there's also opportunity to follow patients for ITP management and long-term cancer pain in terms of trajectory of care. And it frees up the physicians to perform the interventional procedures. So it's really nice as an APP to be able to bond with my patients. And then you allow the physicians to really do what they do best, which is be in the OR and be doing procedures. It establishes trust with the patient when you have a good team. So it's a great niche as an APP. So some things that I've done in my current practice are pre-procedural optimization, so ensuring coordination of care between the disciplines, creating pre and post-op education, and then assisting with interdisciplinary practice conferences. So really setting up those neuromodulation meetings and some of our nerve team meetings between neurosurgery, physical therapy, radiology, and our pain center. All right, so my last slide is just about research. So it's another niche in the practice that is an excellent way to get involved, especially if you're wanting to expand your practice and learn about new things. Once again, as the APPs were on the front line with the patients, it's a great way for the practice, if you are recruiting patients, to have the APP involved because they're seeing the patients on a day-to-day basis. There's also great funding opportunities for APPs to pursue pain research and spine research as well. Great opportunities to get published, especially if you're at an academic center. And then the whole flip side of that is that you can disseminate all the findings to patients and staff, which is a really good intrinsic thing as an APP. So I'm going to wrap it up there with 4 minutes left to go. And I think that we were going to go ahead and take some questions.
Yeah, well done. I mean, I so enjoy the enthusiasm and the collaboration, and I think the scope of work that we've all defined, and I think there's lots of different models. I so enjoy the opportunity to take things back to patients. I think that's really critical because patient access is very important, especially in this evolving world of interventional pain and spine. And I think collaboration, as you all have defined, I think is really critical for success. Whether you use an independent model or a dependent model or a resonant model, I truly believe that APPs, as we've seen in the healthcare system in the United States, a lot of the work that's done to help diagnose and set a trajectory with an inflection point that I think patients can be proud of and that really will impact their lives to a greater degree, really is centered on the work that APPs do. So I really appreciate you, Kelly, and you, Victoria, for you jumping on and doing all this work today. I have a few questions. I know we have some closing comments, or I have some closing comments rather regarding PSPS, but to talk about some of the growing innovative strategies that we have in the pain space. You know, we're sponsored by SPR Therapeutics, and I've had the opportunity to employ some of that work in my practice. And I'd just like to ask all of you, what is the thing that excites you about peripheral nerve stimulation in our pain space, and specifically things that you've noticed with SPR Therapeutics? So we'll start with Patrick Buchanan, and then once you're done, I'll call on somebody else. So Patrick, why don't you start us off?
Yeah, thanks. I get the easiest part, the first one. So I think, targeting different nerves that you can't traditionally get with dorsal column stimulation or DRG stimulation. For example, the shoulder, right? The shoulder can get tough to get, but with peripheral nerves, you can get that suprascapular or that axillary nerve to target to really help, the shoulder pain, especially that older population who can't really lift their arm very well, who's had multiple shoulder surgeries, and nothing else has worked for them. Keeping this in for a 60-day trial, but the dedication that they've had to look prospectively out a year, 2 years out has also impressed me as well.
That's great. Victoria, you came to my practice and chatted a little bit with me and my team in Santa Rosa, both physicians and APPs, in regards to some of the innovative work that you and Dr. Sheff have done. You wanted to comment a little bit about that?
Yeah, I really think that SPR Therapeutics and their peripheral nerve stimulator system has really fundamentally changed how we practice in pain. One of the reasons I think is because it's so minimally invasive, it's so easy. And I tell patients all the time, I would put this in my mom in a second, and I do like my mother. So I always make sure that I say that first so they know I actually like my mom. But, I think it really has fundamentally changed what we do because like Dr. Buchanan said, there's so many options and nerve targets that you wouldn't normally be able to do. Like, if you had someone with meralgia paresthetica and they were doing injections, and maybe those injections aren't lasting for very long, but you're giving them this opportunity to have much longer pain relief than they would have previously had. So the opportunity to give them relief much more than they experience without an implantable battery, without a permanent lead in their system. And so, if it needs to be removed for an MRI, we can do that. So we don't have to worry about MRI compatibility like we would with other systems. So for me, I feel like this opens the door for so many options for patients in a minimally invasive space so that even our older patients are able to tolerate this. Whereas sometimes you might wonder whether or not, from an anesthesia standpoint, they would be able to withstand it. So, like I said, I really think it's fundamentally changed how we practice pain.
Well said. Kelly, let me ask you, you work in an academic center. Has there been a region of the body that you've seen success with SPR Therapeutics and peripheral nerve stimulation?
Absolutely. So I actually had a patient about 2 weeks ago that had tried and failed several therapies, and we've been doing a lot of the acnes area. And this specific patient actually needed serial MRIs and really didn't have a lot of option for other types of stimulation. So we placed the SPR device, and the patient's actually doing really well. So it's been the only thing that's really helped her pain. And it's very it's amazing to see that. So I'm just interested to see how this evolves over time, given the different areas that we're implanting.
Yeah, it's exciting for me to note how fast the procedure is. I mean, when I was introduced to it a number of years ago, it's just as fast or as easy as an injection, and to have the opportunity with enduring relief with evidence prospectively collected, I think is tremendous. Dennis, you're the last person on the panel, and you get the hardest question. It sounds like so. Outside of the work that Patrick's described and Victoria and Kelly, is there an area that you've found success with peripheral nerve stimulation and SPR specifically?
Well, yeah, I just want to comment that I think it is changing our perspective. I think, if you look at traditional pain management, what have we always done? We've tried to target sensory nerves, block them, and when they didn't get sustained relief, we did ablative procedures. And think about this. This may change the foundation of our practice. We may look at ablative procedures now as a last resort. And now, instead of destroying a patient's anatomy, we're actually could place these leads, stimulate it, maybe change the signal in their body without changing their anatomy at all. I think that's huge, and I think that has a profound effect. That if we continue to see the research and the studies show that how good these devices are and how long they can give patients long-term relief with only having them implanted, or temporarily in for a short period of time, 60 days, this may change all of our practices and change the way we see patients, that we go to these devices sooner rather than later and look at ablative procedures much farther down the line.
I've seen that in my practice too, that when you talk to patients about destroying something, to try to cut off a sensory response, there's a little eek factor associated with it because you're destroying something. And we talk about augmentative versus destructive therapies. And I found that the appetite for augmentative therapies is much higher than what it is for a destructive one. With SPR starting in the shoulder and then moving to the back with a lot of published data that I know we presented at PSPS and other national societies. I'm most excited about headache. So, I'm participating with SPR with the headache study that we're really excited about, and so that's ongoing. So, details to follow with that. But I do agree that we're moving away, as Patrick described at the top of the webinar, from opioid-based therapy. I think that we can all agree that that's not a sustainable strategy, and it's not something that we want to continue to do in perpetuity. And relying on science and using electricity and being mindful of anatomy, I think is a formula for success. So I think that concludes a lot of the webinar. So I really appreciate everyone's time. I have some closing comments, but I would like to, again, highlight all the work that you all did during the last hour, talking about not only how your practices are run, the collaborative opportunities that you have with your physician partners, the tribe that you're developing to really guarantee success for patients as best you can, the opportunity to plug in what fills your cup up, whether it's research or whether it's quality improvement or whether it's patient care. And I think all those things are intertwined, but I think the sky's the limit. And I think if everyone approaches a collaborative model with APPs and their physician partners like you all do, I think we're in a good spot. So I really appreciate your time with that. And again, thank you, Sprint, and SPR for sponsoring this PSPS webinar. Lakin, if you want to go to the next couple of slides. So we do have a minimally invasive spine webinar that's coming up next week, moderated by my good friend and colleague, and he's had the privilege, I guess, being the president of PSPS currently. So he's got a couple more months left. So please attend that. In the world of minimally invasive spine, the sky's the limit. And I would echo, as my surgical partners would say within PSPS, that with innovation requires research. and it requires also when to plug those in, and it requires training, and it requires understanding of anatomy, and it requires due diligence, and not only that, but also a sense of peer review. And so I would encourage everyone to think about that as we're moving towards minimally invasive spine. I was texting with one of our administrative team members as we were preparing for these closing slides, and our minimally invasive spine lab, hands-on lab, June 3rd, is sold out. So if there's anything that changes with that, details to follow. Our minimally invasive spine lab for surgeons and fellows is not quite sold out yet. So Michael Dorsey and Brian Sue both are board members of PSPS. I've architected a wonderful event, and so if you as an APP or your physician colleagues, I would encourage you to consider attending. It's in Colorado, so there's nothing bad about that either. It's a joy being on the West Coast. We have this summer webinar series coming up, so in preparation as we prepare to head towards our annual conference, and so details to follow there, but looks like we have them set for the 2nd and the 16th. So we have our little QR code there, so get your cell phones out and take some photos and sign up. As Patrick Buchanan described, we do have a call for abstracts. So without science and innovation and the work that everyone's doing clinically, I think it's important to share those insights and conclusions. So please, if you're doing research, help broadcast the results and share the experience you've had by contributing to the abstract presentations at PSPS. Deadline's August 1st, so you got plenty of time to do it. Similarly, when I became involved with PSPS some time ago, we really wanted to focus on research, and we wanted to empower our members to contribute to research. And a mentor of mine, when I was in fellowship, Michael Stanton Hicks at Cleveland Clinic, said that research doesn't always have to happen in academic practice. It can happen just as well and as robustly in private practice. So to help you along, PSPS has created a funding opportunity, and that starts with a research grant proposal. And so Patrick and his colleagues would evaluate those things, and then again award a few choice folks to come to PSPS with expenses paid, with a couple of nights, and also a guaranteed presentation on the podium the following year, which is always good. I really have been humbled by the work that our annual planning committee has done. And if you love PSPS, you should come. If you love Hawaii, you should come. We're going to be at the Four Seasons. We're going to be there in September. We have a robust APP meeting that's going to occur the Thursday of the event. So Dennis, I think you're helping collaborate and work on creating that. So any ideas? When we have APPs in our practice, I always tell them that we need to identify what fills your cup up, and then we need to fill it up. So please, if there's any questions or comments or insights on what we can include in that agenda, please feel free to reach out to us. We're more than happy to accommodate that, because we want you to be successful in this world of interventional spine and pain. So thanks for spending your Thursday with us. I don't think there's an important basketball game. Well, actually there is. I think the Lakers are playing. Not that we care, because I'm a Golden State guy. So thanks for all of your attendance, and look forward to seeing you all on the circuit. We'll talk to you soon. Thanks, faculty. Really appreciate you all.
Thanks, everyone. Have a good night.
All right. Bye-bye.
Thanks, guys.